Hail Abduli will be replacing Dr. Abdullah Al-Asiri.
Thank you.
Thank you.
All right.
Assalamu alaikum. Good morning, ladies and gentlemen. Obviously, I'm not Dr. Abdullah Asiri. I'm Dr. Hail Abduli. I'm the newly appointed Director General of Infection Prevention and Controls. And Dr. Asiri apologizes for not being able to make it to the conference, so he sent me his slides. So I looked over them, and I'm gonna basically go over them with you. Where's the... So I apologize for any unclarity in the presentation because, as I said, these are Dr. Asiri's slides. Probably I would not be able to take questions as well. Can I have it in? Yep. Okay, so his talk is about antimicrobial resistance, local perspectives. And WHO has published a document about the strategy for containment of antimicrobial resistance. And in that document, they endorsed or indicated the need for established infection control programs with responsibility for effective management of antimicrobial resistance and ensure that all hospitals have access to such a program. That's a good statement, but to put it in practice is not as easy in many countries. So they had this slogan as early as 2011, and maybe even before that was raised to combat drug resistance. And they mentioned that if no action today, no cure tomorrow. And being a clinician, seeing a patient in ICUs, we have patients that we could not cure with antibiotics because of resistance. So what is the impact of multi-drug resistant organisms on infection control program? Healthcare facilities, particularly acute ones, are important sites for both the emergence of resistant organisms as well as transmission of these organisms within these institutions. And that's because of the intensity of antimicrobials used together with a population that are highly susceptible to such infections. So it's the right environment for resistant organisms. And some organisms may be restricted to specific risk groups with little impact on community, like drug-resistant fungi, and many of them are inherently resistant, but they are restricted to certain group of patients, mainly the neutropenia, bone marrow transplant, etc., or an organism like Burkholderia, where it's associated with chronic lung disease, especially cystic lung disease like cystic fibrosis or bronchiectasis. However, our main problem is those organisms with impact to most patients in the hospitals as well as the community, like the ones we know, the ESBLs, MRSA, VRE, CRE, etc. And infection control program act primarily to limit transmission of resistant organisms among patients. And some infection control activities actually is towards giving antibiotics, which is kind of perplexing, but we do it so we don't get more infections, like prophylactic surgical antibiotics. So overall, infection control programs, they have some activity in controlling antimicrobial resistance, particularly when there is an outbreak of a resistant strain identified. So the effectiveness of infection control programs has been significant up to in controlling healthcare associated infections. Particularly, the impact was in the range of 30 to 50% according to the Senex study. However, the specified role of such programs in containing antimicrobial resistance has not been reported. And the assumption would be that these programs reduce overall hospital-associated infections, and within this group of infections is the ones associated with resistant organisms. So effectiveness of infection control programs not necessarily straightforward. Usually, and what we think it's a good program would lead to less multi-drug resistant organism infections, then less antibiotic use, then less pressure, and then reduce multi-drug resistant organisms. But highly immune compromised, those are the most likely to get multi-drug resistant organism infections, and typically most of these infections are not preventable. And the effect of infection control program on the total burden of colonization of multi-drug resistant organism has not been adequately evaluated. So prophylactic use of antimicrobials. In a way, we use them so we reduce subsequent infections, which may be a serious infections and take long time to treat or difficult to treat. On the other hand, we give antibiotics, which we are kind of trying to avoid that and to have less pressure of antibiotics and less resistance. So local data on antimicrobial resistance. This is a summary of several studies from Saudi Arabia on MRSA. And you can see here that about a quarter of the cases of Staph aureus in several of these institutional studies are due to MRSA, with a prevalence of overall of about 0.23 per 100 admissions to hospitals. And this is, Professor Natwani has already shown you this, this slide indicating the high level resistance of several organisms in the Gulf region or countries, and especially in Saudi Arabia. You can see the Acinetobacter, the Pseudomonas, and also some of the Enterobacteriaceae. And this is the data from one of the referral institutions in the kingdom. And you can see over time, resistance of Acinetobacter baumannii has been on the rise to carbapenems. And you can see imipenem and meropenem declining over time. This is imipenem, meropenem, and imipenem and meropenem here. And this is the data published by Hussam Zawawi and his colleagues in Clinical Microbiology reviews on the circulating resistant genes for mainly Enterobacteriaceae. And you can see several of the known genes has been reported in several countries in the Gulf, including the OXA48. And there is a measuring data I know about that. OXA48 is really highly circulating in several hospitals in the kingdom in Saudi Arabia. And of course, NDM as well, 1 and 2. So we are likely to see more and more of these resistant genes circulating in the Gulf. One of the areas is to have a good microbiology infrastructure to be able to have a successful control program and infection control, and of course antibiotic stewardship. And this is a survey done I think by the Infection Prevention and Control at MOH. 14 hospitals were surveyed, and they used the CDC patient survey component annual hospital survey. And the total number of blood cultures from several of these hospitals, some are small hospitals, less than 200 beds, and some up to 1,000 beds. And they were ranging about 80, just above 80 blood cultures set per week throughout. This is the typical antibiogram. It's a little bit busy. This is for gram-positives. And at least from this institution, I believe probably this is King Fahd Medical City, but I'm not 100% sure. They have no VRAs. At King Faisal Specialist Hospital, where I work, we have several VRAs, but here none. And basically, MRSAs, several maybe community acquired. As you see, susceptibility to bacterium, clindamycin, and macrolides in the range of about 60%. So indicating also a significant community type of MRSAs. This is even busier with the gram-negatives from the same institutions showing basically the typical antibiogram produced. I'm not going to go into the details of this antibiogram. So how about the infection control programs? Again, another survey has been done throughout the kingdom. This was actually large, more than 20 hospitals surveyed throughout, to see how is the infrastructure for infection control program as we are embarking on an improvement of what's in place. And as I would say, we would expect, we had severe limitations in infection control. For example, the human resources, we are working at 50%, hardly 50% throughout in different regions in the kingdom. About surveillance, having established surveillance, also close to 50 to 60%. Microbiology lab support, also hardly reaching the 60%. Knowledge and availability of technical guidelines, again, hardly in the 50-60 range. And at the end, a few questions on that survey. 25 hospitals were surveyed, and the question was, does your hospital have an antimicrobial restriction policy? And 84% they answer yes. Then if they have a committee for infection control, and 64% answered yes. Then if they have a data on multi-drug resistant organisms, and as you see, very, very limited data they are producing about common known multi-drug resistant organisms. Do you have a preoperative prophylaxis? Everybody seems to give preoperative prophylaxis in all institutions surveyed. But do they have a surgical site infection bundle in which it has 3 elements related to antibiotic use, and close to split here. And then do you report misuse of antibiotics to end users? And again, another split here. And I'm not so sure if they understand the survey well, because I think it's way, way lower. And then do you have a de-escalation policy in the ICU? And most of them, they don't. Again, I would expect even more than 64%. So with that, I conclude the presentation of Dr. Asiri. Thank you for your attention.